everybody. Thank you for joining us this evening for our second webinar series for Gynecologic Cancer Awareness Month. As probably most of you know, September is GYN Cancer Awareness Month, and we here at the Kelly Gynecologic Oncology Service are working to bring a series of educational seminars, webinars in the modern Zoom era of COVID to those who are interested. And our first one was an introduction to our service and our teams. And tonight we're joining for a session on what we have called critical intimacy. And intimacy meaning closeness in the broad sense of the term in all ways. And critical because it is something that is incredibly important to all of the women who we help who have been diagnosed with gynecologic cancers. And so it is a critical need to address. It's also something that most of us blush a little bit when we talk about or don't necessarily bring up as much as we wish we did. I'll say that as myself as a provider, I wish I brought it up more in clinic sessions with patients. And I think probably many of my patients wish they brought it up more with me. So this is an opportunity to have a little chat, a little moment of open dialogue and conversation. And we've brought in some experts to help us with that, to expand sort of our knowledge and our expertise. So tonight we have Tammy Senn and Teasley, and they're going to help us, and I'm going to let each of them introduce themselves. So Tammy, do you want to go first and introduce yourself?
Sure. Hi, everyone. My name is Tammy Senn, and I work with the Department of Gynecology as a certified nurse midwife. I typically don't work directly with the oncology service, but I do work in close proximity with that department. I'm here tonight because I do have a special interest in sexuality and how it's affected by our health. And I've always believed that, as Stephanie said, we don't bring it up enough in healthcare. And I hope that we can open some doors so that you're more comfortable to bring it up and know that we are open to talk to you about it and to help you with these issues because they are important parts of our life. I have a postmaster certificate from University of Michigan in sexuality counseling and education, and I am an ASECT certified sexuality counselor. ASECT is the American Association of Sexuality Educators, Counselors, and Therapists. So this is a national organization of professionals who have very rigorous educational and ethical standards surrounding helping you with sexuality. So hopefully we can get you some good information and answer your questions. I'm sure that you have a lot of things that you want to talk about that you've been sort of embarrassed or shy about bringing up.
Teasley, would you like to go ahead and introduce yourself?
Yes, perfect. So my name is Teasley, which is my last name, but that's what I go by. I'm a physical therapist specializing in pelvic health diagnoses. I did my graduate studies at University of Southern California out in Los Angeles. And I came out to the East Coast of Johns Hopkins to be the inaugural pelvic health PT resident here, which from which I just graduated 3 weeks ago. I will sit a board specialty exam for pelvic PT in the upcoming spring. But yeah, so I'm now a full-time pelvic health physical therapist at Johns Hopkins, and really excited to be able to talk about this stuff. So I treat a lot of folks who are survivors of cancers, as well as folks who have pain with intercourse and general bowel and bladder dysfunction as well, amongst many other things. And so really for me, there's nothing off limits. I help people pee and poo better. I help people have better sex. So this is my jam. And fun fact about me, since I was told we should, a teaser, I was an avid roller derby player before I moved to Baltimore, and now I still do a lot of skating, roller skating all around town. So if you see anybody out and about with short hair like this, it might be me.
Very nice, very nice. Thank you. We are very, very glad that you both are here and bring a lot of wisdom to the conversation. So thank you for that. And our conversation tonight, as I said, I've used the word casual. I think all of us want to sort of have a back and forth amongst ourselves, and then I mostly am going to listen a lot to their expertise. So I hope Tammy and Teasley will have back and forth. But certainly for any of you who have joined us, you can enter questions into the chat and we will incorporate those into the conversation. So if something gets said that you need clarification, or you just have a question that you came with tonight that you want to be sure that we answer, don't hesitate. go ahead, pop it into that. There's both a Q&A and a chat. You can choose which one you want to use. We will monitor both of them and make sure that your questions get answered. So feel free. So our conversation, as I kind of mentioned, is going to be a little bit of a Q&A, and I'm going to start us off with that Q&A conversation piece with what I think is the starting question, which is, how do we even start this conversation? So how do you recommend, or what advice do you give people when they come to you and say, like, how do I even start the conversation about sex and intimacy with my doctor? What do I say? What do I bring up?
I would say, however you're comfortable bringing it up, whatever language you're comfortable using. The one piece of advice I would give is don't save it for the last part of your visit. These are usually very time-consuming questions, and we want to make sure that we spend enough time with you to make sure that you have the answers that you need and the information that you want. And understand that sometimes your provider, depending on their level of training with sexuality, may be as nervous as you are to answer these questions, but that shouldn't stop you. That shouldn't be a reason not to bring it up. Teasley, what do you think about that? Do you feel?
Well, I want to add and empower you folks to know and to understand that sexual intimacy is considered by the World Health Organization as an activity of daily living and a fundamental human right for you to have access to knowledge in healthcare and education regarding sexual intimacy, sexual pleasure. And so I really want to affirm that this is something that we absolutely care about our patients being able to ask about and to be able to participate in, because it's truly considered an activity of daily living, just like eating, dressing yourself, being able to go to the bathroom. So these are really considered fundamental to our daily enjoyment.
Yeah. And I'd like to add to that too, don't be afraid to be very explicit when you bring up sexuality. If you say to me, I'm into kink, I'm into anal sex, any of those things, whatever activities that you participate in, we can take it. And we want to help you. And sometimes being very explicit about what activities you enjoy or engage in and want to continue to enjoy and engage in, help us to give you proper guidance, because depending on those activities, we may have different advice for you that will help to do that safely. Because as Teasley said, this is an important part of your life, and we want you to be able to continue to enjoy that intimacy in whatever form or method you already do.
Yeah. What about with partners? So you bring it up with your doctor in the office, but oftentimes I think probably people bring it up with their partners at home or in at some other location, either before the doctor visit or after the doctor visit. And so what are, before the treatments, leading into the treatments, after the treatments, sort of at many different points, what are some tips and what are some ways to start that conversation? Or what are some critical elements of that conversation? How to start it, and then what things to consider including in it also?
So one of the things that I find often happens with couples is maybe both partners miss the closeness and the intimacy of their sexuality. But we're not really a culture that talks about our sexuality. We're sort of taught that it just happens. And so when it becomes difficult, and for most couples at some point in your life, it does become difficult. Most couples will have sexual challenges at some point. I think we're really unsure how to bring it up with our partner. And one of the biggest mistakes that I hear couples say they make is they reach out sexually first. And one of the things I would recommend is reach out to your partner for intimacy in a non-sexual way first. Make sure that you have those bonds, and then talk about what it is about that closeness or what it is about sexuality that you miss. Do you miss the orgasm? Do you miss the touch? Do you miss whatever those silly little intimate things that only the two of you do together? what is it that you miss? And focus on that first. And then take whatever baby steps you need along the way to get yourself back on the path that you want to be on. Cancer really can change your sexual functioning. Cancer can really change the way both of you feel about yourself. And there's a whole lot going on outside of your life and in your sexuality besides your cancer therapy. So it's important that you're talking about all these things, talking with your health providers about all these things. And sometimes just going for, I want to have sex, maybe isn't the most productive way to do it. And sometimes addressing it in that way can make your partner, who is the person who's getting treatment, feel like, oh gosh, this is just one more piece of pressure on me that I don't think I can do right now. Teasley, what do you think about that?
Yeah, and the lines of what you're saying about one more piece of pressure, I find that sometimes partners feel like all of the education, or I think sometimes patients feel like all of the education that we give you in your visits, that you have to be the person who then passes that along to your spouse as well, so that you have to have this also educator role. And I'm sure that the group here probably has the same policy I do, as I welcome partners at sessions with me so that I can take some of that burden away from you having to then pass that information along to a partner who, you know, may not be familiar with the anatomy, right? And you may not be familiar with the anatomy, just for example. So I love to have partners come into the office so that I can give them the same exact, you know, educational spiel that I give the patient, and teach them about their own anatomy, and just unburden you so that you don't have to be that expert saying, well, this is what my homework is. This is how my PT or my, you know, doctor said I need to do it. So that's a service I think we offer that I really hope patients will take us up on.
I think that anatomy point that you made is such a good one, because the questions that patients, I do almost always find they do feel comfortable asking, is the anatomy questions that maybe they'd never had an opportunity to ask anybody before, but now I'm talking about surgery on body parts, and so we can talk about it. The like most simple sort of non-crazy example is like, what does even a hysterectomy mean? That's probably like one of the questions that for us, you know, becomes most prominent, and differences like what's the vulva versus the vagina when we talk about something that we found in one of these locations, these sort of very basic anatomy questions. And you sort of pulled up your model. And so I wonder if you both could go through and give us some of the key, like what's the key anatomy that we all need to know to be able to start having these conversations, because it does probably help to have a little bit of an understanding of that anatomy when you're trying to describe what's working or what's not working. So do you want to, Teasley, you pulled up your pelvic floor model there. Do you want to start, or Tammy, do you want to start? Anatomy.
Teasley, you can start.
Okay, great. And so as a physical therapist, just as any physical therapist is, I specialize in the musculoskeletal system and the connective tissues and how those interplay with our nervous system to promote functional movements and functional activities. And so just a little bit of, you know, getting you oriented here. Right now, the pelvis is facing you as if it were my pelvis. Okay, so you're looking at the front of the pelvis here. And we've got our bones here on either side. And so you can see here, this is at the base of the spinal column, right? And if you do a bottom-up view, all of this red you see here, that's all muscle underneath your skin. So you have an enormous amount of muscles in multiple layers that can be involved in pelvic floor dysfunction, in addition to also connective tissue and nerves in that area, which can be impacted by each of the different cancer treatments that we've already spoken about. And so just really broadly speaking, from the musculoskeletal standpoint, from the standpoint of the muscle function, our pelvic floor muscles need to be both strong and flexible. And so I think that's a really important point, that it's not just about strengthening all the time, but it's also about coordination of these muscles. And so these muscles need to be strong to be able to hold back urine or stool, okay, to prevent leakage, right? And they also need to be strong to be able to have good sexual appreciation and sensation, and strong and fulfilling sort of orgasmic function. And then on the flip side of the coin, they need to have good flexibility. These muscles need to be able to relax and lengthen to allow passage of urine or stool, to allow the vaginal opening to become more open, more patent, to allow for penetration without pain. And so I just think that sometimes we forget that these muscles not only need to contract and lift and squeeze really strongly, but they also need to be able to relax and lengthen and let tension go. So oftentimes when I'm treating folks after cancer treatment, we're focusing a lot on that let go part.
So I have a couple of different models. I have a very different pelvis. And this one is, the genitals are here. This is the vagina. And this shows the position of the uterus and the ovaries and the fallopian tubes. So as Stephanie said, sometimes just knowing where these organs are in the body and what the surgery means can be a challenge, because we don't always get good education in our formative years. The other thing that I like to use, this is called a vulva puppet. And this is a model of women's external genitalia. So you have the clitoral hood and the clitoris here. You have the labia minora, which are sometimes called the little lips, the labia majora, sometimes called the big lips, and then you have the vaginal opening. So this is what we would call the vulva, and the vagina is a very different part. And so sometimes you also have the urethra here, which is where you urinate, and the rectum would be lower in this area. And sometimes we don't even have that sort of education to know, and it's not an area that women can look at easily. So often they're not as acquainted with their genitals as you might think, because they're kind of difficult to see. But I would encourage you to take a mirror if you never have and take a look and see what your genitals look like, so you can get acquainted and see what all these things are. The other thing I often like to talk about is the clitoris. So most of us know that the clitoris is sort of the magic area that we stimulate when we're looking for orgasm, or we're trying to produce pleasure during sexuality. Most people don't realize, and this is not to scale, that you only see a tiny portion of the clitoris. I don't know if you can see this little section right here is the only part of the clitoris that is outside the body, and most people call that the clitoris. What they don't know is that the clitoris is kind of like an iceberg. There's all the rest of this stuff inside your body that responds to stimulation, has erectile tissue just like man. So female bodies get erections too. They just respond a little bit differently. And a lot of people have never seen anything that looks like this and don't know that their body can respond that way. So regardless of what happens with your anatomy, there are still other players in your sexuality and in your ability to have pleasure later on, even though your body may be different now.
Yeah, and piggybacking off of that, Tammy, I really like to kind of explain to folks as well that orgasm is, as a sensation or as a phenomenon, exists in your brain. So because we typically associate orgasm with stimulation of certain genital organs, we think that if those genital organs are somehow changed or different, or if there's decreased sensation, that may mean I may not be able to orgasm, or I may not be able to have enjoyable intercourse anymore, or masturbation anymore. And what we actually know is that our brain is beautifully adaptable. And because orgasm is a function of that brain, of our central nervous system, we have many, many, many cases of folks who have, complete spinal cord injury, no sensation from the waist down, and can have orgasm through, touch, sensual stimulation of other areas. And so I just think that that's a beautiful point to bring up and to mention, that orgasm is an incredibly complex sort of phenomenon.
And orgasm isn't the only important part about your sexual relationship. There is so much more to sex that, again, our culture doesn't always talk about, acknowledge, or address. And for some people, even though orgasm is very enjoyable, there may be other parts of their sexuality that are more important to them. So we need to acknowledge that. And maybe if you've never had that conversation with your partner, or you've never thought about that for yourself, maybe, think about, what is it about sex that I really enjoy? And what if I have sex and I don't have an orgasm? Is that okay? Because for a lot of people, that is okay.
Mm-hmm. Yeah, I really like Tammy, and I think it's important to be able to give yourself permission and to be able to communicate with a partner if you're having partner intercourse. If there's a certain point at which you feel like you don't want to keep going on, or you feel satisfied with the encounter as it was, there doesn't have to be that end goal. And sometimes you just need to be given permission to say that, what we've done together as a couple, this intimacy, this has felt really, really wonderful. I feel very close to you, and I feel very satisfied.
Yes, and your sexuality doesn't have to start at the genitals, and it doesn't have to end at the genitals. There are a lot of other erotic body parts, and there are a lot of other really erotic things that you can do, especially if you're going through this period of transition where, because of your treatment, your body is changing or your partner's body is changing. You can learn new ways to be sexual that are just as enjoyable as they've always been, maybe better.
That's a good line. Certainly being open to the dialogue and changing the way we're willing to converse about it opens up a whole realm of possibility that I think can be a unique and actually wonderful component of this. We sort of, in our survivorship program, we often use the language that we don't just want to survive the cancer, we want to thrive through it. And so to find these moments or these little ways that maybe actually something, some little bit of good or some bit of thriving, some new change that leads in a good direction is always important. You both said so many gems that I would love to pull on and sort of talk more about that I don't quite know where to start. But I want to go to the idea that it's about more than just the physical, that our intimacy plays, that there's more that contributes to that. And you sort of said, what's at the head up, both in terms of different body parts is one component, but that's still physical, I would say. But then also that there's a lot that's going on that then contributes to our experience of intimacy. And so could you talk about, when people come in and maybe stress or worries or something not, body image issues, sort of things that are not necessarily the physical experience of intimacy, but when those are things that people raise, what are some of the things you recommend, questions to ask and discuss with your partners, or ways to approach these things, sort of that very important but non-physical element of this? Was that too much?
No, not at all. Okay. When I think of intimacy, I often talk with clients about how intimacy and sex are not necessarily the same thing, even though in our culture we kind of use intimacy as a substitute word when we really mean sex. When I think of intimacy, what I think of is that each and every one of us has this deep desire and need to feel like we are seen and we are heard by at least one other human being, that we're acknowledged for who we are, for our essence, our personality, our likes, how we see the world. There's so much to us, and we want to feel that there's somebody basically who gets us and who hears our story and sees us for who we really are, that we're known and we're understood and we're acknowledged for that. And if it's been years since you've looked at that aspect of your partner, or maybe that aspect of yourself, because any sort of long-term illness can really make us be very introspective about who we are and what our life has been and what we want it to be. That's actually a really good starting point for intimacy with your partner and to rebuild a new type of sexuality if you're finding it challenging right
now. I want to go back. One of the questions that popped up in the chat was a question about pelvic floor. And the question of how do you relax? I think all of us sort of think about the Kegels strengthening, contracting, but what are some strategies to relax the pelvic floor muscles? And yeah.
Right. Good question. So the pelvic floor is very, it's unique amongst muscles we call skeletal muscles, meaning muscles that are under our voluntary control, like our biceps, like our shoulder muscles and so forth. It's unique because these muscles are always a little bit active all the time. It's a good thing because it prevents leakage of urine or stool. You know, even while we're asleep, they're always a little bit active. But the key point is that those muscles, we don't want them to be working harder than they have to when they don't have to. And so I think a lot of times what can happen is either those muscles are kind of clenching when we do have tension, when you're cut off in traffic, when your boss talks to you about a work deadline, and we just kind of have this compulsion to squeeze our glute muscles or squeeze our pelvic floor, and you may not even realize that you're doing it. And so the pelvic floor is really unique, like I said, because unlike a muscle like the biceps, where we can stretch it by using the opposite muscle, the triceps, to kind of force that muscle to lengthen, we don't really have that same relationship of an opponent muscle of the pelvic floor. But we do have something kind of similar, and which is really neat, is that our thoracic diaphragm, so the muscle that helps us with our breathing, when it contracts so that we can inhale into our lungs, that muscle moves down, our pelvic floor actually should relax. So there's a pistoning relationship there, or an opponent sort of relationship. When our thoracic diaphragm contracts, our pelvic floor relaxes. So we tap into that a lot in pelvic PT, but also even just in general physical therapy for kind of calming the body with diaphragmatic breathing, because the diaphragmatic breathing is known to support sort of our parasympathetic nervous system, that rest and digest sort of nervous system. But in addition, with pelvic PT, we can think about not only drawing our breaths really into our belly instead of our chest, but also drawing those breaths, really feeling them sink heavy, heavy, heavy into that pelvic floor with each inhale. And so that's the first exercise I do with every person who comes with any kind of pelvic floor pain, is I have them practice diaphragmatic breathing. So just a super simple way to do that. You can do it at home. It's usually easier to do laying down with your knees propped, but you can also do it sitting, is to put one hand on your chest and then one hand on your belly, okay? And trying to do an inhale where you're really making this belly hand rise more so than this chest hand. And this is a really, really simple thing you can do throughout your day. Even sitting in your chair, you can practice kind of making the belly hand rise and this hand be quiet here. But yeah, laying down with knees bent, propped on pillows is great, so that you can feel as very, very relaxed just in your body, really feeling that pelvic floor heavy and lengthening on those inhales. So that's the first key one I give. And then it can get a little bit more sort of specific and involved. And this is where, you know, seeing a pelvic PT to be able to guide you through some of these exercises can be fruitful. But sometimes I'll have a patient do a gentle pelvic floor contraction, as long as it's not painful to do so. Gently squeeze and lift their pelvic floor as if to hold back urine or gas, and then really focus on that let go part of it. That lowering, sinking heaviness of the pelvic floor as you let go the contraction. So it's called a reverse Kegel. And then one other one that we can utilize, but again, it's kind of a little subtle, it's more of a subtle scale, is gently bearing down, very, very gently bearing down, as if to pass gas or an easy bowel movement. It shouldn't feel like a strain, but just a very subtle lowering of those tissues. And that should also kind of help achieve that lengthening of the muscles if they're tight. But if you are experiencing any symptoms that feel like kind of this tightness or this squeezing, pain with intercourse, pain with bowel movement, urinary urgency frequency that doesn't seem to get better with going to the bathroom, those are great diagnoses to come and work with a pelvic PT so we can show you how to do that and practice that in the office.
Those are great examples, and they kind of lead into sort of some of maybe the specifics that we could talk through, because there are lots of words and ideas that get passed around. And I think one of the things that as a physician, patients often will, with my hands on the door walking out, Tammy, that was like a perfect descriptor, like say it early, say it often. In our webinar last week, Amy Brown did a little blurb when we asked the question, what do you wish every patient knew? And she did this so much more eloquently than I did, but she had sort of a phrase where she was like, bring it up early conversations. And so this is, when you mentioned that, it made me think of Amy, and this is a different context where that early conversation is important. But one thing patients often will bring up is vaginal dryness, vaginal irritation. Oh, Amy Brown, do not wait to communicate. That is the phrase, do not wait to communicate. She just sent me a message. Thank you so much. It's just such a great, it's perfect for this also, right? All critical conversations, don't wait to communicate. I think sometimes what patients are willing to say in the office, and I think actually this applies to patients whether they've had cancers or not, because it's often a symptom of menopause and a menopause issue, but vaginal dryness, vaginal irritation is something that oftentimes people are willing to bring up. Pelvic pain, definitely something that often people are willing to bring up. I think sometimes the door opens a little bit around like a concrete symptom, as opposed to, so as a physician, that's what I often experience, is that concrete symptom will creep into the conversation. So when we talk about vaginal dryness, people talk about lubricants and moisturizers and what's the difference and how do we know when to use which and what do we do? And there's lots of things on the shelf actually. And so what are our options and what do we think when we think about lubricants and moisturizers, tips and tricks? What are your thoughts?
Would you like to go?
Sure, I can give my my 2 cents here. So a lubricant is not intended to stick around in those tissues. So it's used for a specific purpose. It's used for, insertion of in intercourse, fingers, toys, penis, etc., or for inserting a device or something like that. But that lubricant is not really intended to stick around. Versus a moisturizer is something that's intended to stay in that tissue, kind of keep drawing water or keeping water in the area. Yes, lubricants are for love making, moisturizers are for maintenance. Right.
Yes.
So ideally with a moisturizer, you would want something that would stick around and keep those tissues feeling more supple for 24, 48 hours. So there's going to be different ingredients there. And also generally speaking, when it comes to lubricants or it comes to moisturizers, we look at few simple ingredients generally in my experience is better, which unfortunately is not always what you're going to find over the counter at the drugstore more often than not. But so things like slippery stuff is a really nice few ingredient water-based lubricant, for example. Just to prevent extra perfumes or, we want to avoid things that might potentially irritate tissue, which is already irritated.
And I'd just like to clarify what Teasley said, that lubricants are typically used at the time that they're needed for whatever activity you're doing, whereas moisturizers, as she said, are for maintenance. So they're typically used, usually for most people, on a 3 times a week schedule. So you want to keep that maintenance, as she said. And I completely agree. As a quick rule of thumb, without mentioning name brands, the best-selling, most popular name brands of lubricants that are available in your grocery store, your discount store, your drugstore, are not the friendliest to your vaginal tissues. And some of them actually can further damage your vaginal tissues. So don't skimp on your lubricant. Go luxury if you can. And usually these are going to be things that you buy from a specialty retailer. I'm a huge fan of Good Clean Love. Most of your silicone lubricants are very similar. And we didn't really touch on that, but there are basically 2 types of lubricant. There's a water-based, which is either based on water or aloe products, or there's a silicone lubricant. And for women who are menopausal, you're actually probably going to get better results from using a silicone lubricant. But if you're working with Teasley or you're doing dilator therapy, or if sex toys are part of your repertoire, silicone lubes do not mix with silicone products. It will melt your expensive products. So
Yes.
this is a time when you either want to use the water-based lube or put a condom on your dilator to protect it. Condoms aren't just for protecting your partner.
Very good point. Yes, there is a whole line of dilators that have silicone coatings, which is meant to be very, body friendly. It feels a little nicer on the tissues. They're in colors, so they look kind of cool. But yes, just as Tammy said, you want to be careful that you're not mixing silicone lubricant with silicone toys.
Mhm.
And you may have to experiment before you find the lubricant that gives you the best results for whatever activities you're doing and what you're looking for.
Your comment about the irritation, I think certainly, Teasley, you explicitly mentioned scented products. And I know sort of anybody who helps patients with vaginal health at any age, one of the first things we ask is, are you using any scented products? And then we go for those gentle soaps that are unscented that maybe our grandmothers used that have been around for a long time as sort of our first go-to, a lot of us. Are there, when you look at a label of a lubricant or a moisturizer, you mentioned some things are more irritating. Is there anything that should be avoided? Like if you see an ingredient, is there certain ingredients that you should say, oh, I need to pick a different product because it has this ingredient, or is it a more subtle ingredient issue?
I would have to say both. It can get pretty complex when you're looking at lubricants, and unfortunately, there's not a lot of oversight in how these products are produced or what goes into them. Really, one of the biggest things that you look at, and it gets into sort of a complicated conversation, is the pH of the lubricant and something called the osmolality of the lubricant, which if you have a very high osmolality lubricant, which is why I recommend against some of the popular ones, it can actually further dry your tissues out and create irritation. Unfortunately, though, you don't usually find that information on the label.
Yeah. Okay, that is definitely one of the challenges. Now you mentioned dilators and dilators versus vibrators and when for which, and we use a lot of dilators for patients who have had radiation, pelvic radiation therapy, and they're oftentimes challenging and not popular things to use. So when do you recommend one versus the other? And what, for those people who should use more of a dilator product, are there other dilator options that might be more comfortable? Are there tips and tricks to how to use it? Is one better than the other in different situations? Thoughts?
All right, well, this sounds like a good topic for me to wax poetic. So, dilators, or just generally speaking, devices that we're using to improve comfort with vaginal penetration or maintaining depth or width of the vaginal canal. There can be a few different sort of techniques that we use, and it will really just depend on your presentation and the kind of treatment that you have had. So for example, somebody who has had radiation to the pelvic area is more likely to develop scarring of that connective tissue, in which case a dilator is, so when I'm talking about dilators, I'm talking about, generally speaking, typically a cylindrical type of device, but they can be different shapes, they can have curves, they can have different, textures, but we have some very simple basic ones here. So this is a very large one. And then we also have as small as about 1 centimeter in diameter. So if we're talking about preventing scarring, for example, after radiation, then we really want to be providing a prolonged stretch of those tissues. And so we know that connective tissue needs these kind of long stretch times. I'm talking in terms of more like, several minutes, 15 to 20 minutes at a time, just to make sure that those tissues are not kind of scarring down with regular use. Now, if we're looking at pain that's coming from the muscle component, so if these muscles are holding onto a contraction or have trigger points or spasms, then we might need to be a little bit more thoughtful with a smaller dilator, one that we can actually specifically pinpoint muscles that may have little trigger points or knots in those muscles. And again, that's something that a pelvic PT or a physician may be able to kind of help point out to you. I wouldn't expect anybody to just be able to go with a dilator and say, yes, I have a trigger point here. But when you know where they are, then you can thoughtfully use that smaller dilator, like this one that I had shown you, or one that has a curve, to actually hold on to that little trigger point there, apply pressure until that muscle relaxes and lengthens. Kind of like a deep tissue massage, like you would anywhere else, any other muscle that has a knot in it. And then a third use of the dilator is for just general desensitization of those tissues. So a lot of times agents like chemotherapy can have an impact on our sensory nerves. They can make that area more sensitive, or anytime you have surgery to an area, those nerves can become more sensitive. And so what we can do is do what's called progressive desensitization. So I think many people can relate to, if you have a scar, like a surgical scar, that area might be a little bit more sensitive afterwards. And so sometimes touching that scar, moisturizing that scar, looking at that scar regularly helps our brain to reintegrate that tissue so it's less sensitive. So we can use a dilator the same way for those tissues if they're very, very sensitive. Again, which can happen very commonly in addition to the connective tissue or the muscle component.
And so I guess I'll tackle the vibrator half. So many uses. I mean, we typically just think of the vibrator as a sex toy. And it can be a great way for you and your partner to sort of explore the changes that are happening in your genitals as a result of treatment. To find, one of the things that I recommend with or without a vibrator is something called body mapping, where the two of you can actually take a drawing, or you can spend time together and find out how your body now responds to touch in these areas. So maybe you touch different parts of the genitals that used to be pleasurable, and you say, is this still pleasurable? Do you like light touch here? Do you like deeper touch here? Or maybe this was an area that you liked to be touched, but now it has a trigger point, or maybe it's tender or painful, and that's not a place that you want to be touched when you're trying to be sexual. And if you find that some of these areas are a little bit problematic, sometimes the vibrator with different settings can be a way to ease back into touch for those areas. The vibrator, what we often recommend it for is to help with perfusion. Think of it as sort of like an internal massage of these tissues to help increase blood flow. The other thing it can also help with is if you have scar tissue, to sort of massage out that scar tissue and to help you be prepared if you want to return to intercourse. So don't be afraid of the vibrator. And if you're not sure of one to choose, you can always ask your healthcare provider. But if you want a basic rule of thumb, start with something that's small. Start with something that doesn't have a lot of bells and whistles, but does have variable settings for either vibration pattern or what they might call speed. And try to choose something with a very simple shape that it doesn't have a lot of curvature, doesn't have a lot of, excess different shapes that you have to navigate. And then you can always move to something that's a little less intimidating once you feel comfortable using a very basic vibrator. So don't just think of it as a sex toy or something sleazy. It can be a very helpful tool.
Right, exactly, Tammy. That desensitization with vibration, that can be very, very helpful, right? Because it gives your body something different to focus on, something that can be a non-pain stimulus and reorganize your brain-body connection of that tissue in a more pleasant way, right?
And I want to add, a common misperception that we hear from people is that if I use a vibrator regularly, it will desensitize my nerves in the genitals. And that is not true. Your
Right.
fingertips are one of the other most sensitive areas of your body, and they don't become desensitized because you touch things and feel things with your fingertips. The corpuscles, as they're called, or the nerve endings in the genitals, actually are specialized and respond very well to vibration, and that's why vibrators work so well for genital stimulation. So don't be afraid that these are going to become a problem. Don't be intimidated that this is going to change your sexual response. It actually can help to improve it a lot.
Yes, I think that was good that you pointed that out. So when I say desensitization, I mean from the pain, that excess pain perspective, but certainly not in this perspective of you're going to feel numbness if you're using a vibrator. But to decrease that excessive hypersensitivity that may be associated with like a post-surgical or chemotherapy sometimes. One really simple other thing that I want to add into that mix is don't forget that heat to the area. For all of these tissues we've been talking about, heat helps with muscle relaxation, heat helps with connective tissue flexibility, and it helps increase blood flow, which can help with lubrication and arousal for intercourse. And so simple things like a heating pack to your low abdomen, or you can even make a little heating pack with uncooked rice and a sock that you tie a little knot off on. Microwave it, make sure it's not too hot, test it on your inner wrist first, and then, you know, keep a layer of clothing in between your vulva and the heating pack. But then you can apply that little heating pack, mold it kind of right over the vulva, and that can be a nice Kickstarter to kind of help that blood flow, help with that lubrication, and that pliability that we associate with arousal.
You had sort of mentioned sort of worries and anxieties and restarting things after not. And some of our patients, we've been focused on couples. Some of our patients are not coupled and thinking about getting, you know, potentially dating again. And what sort of is, as people are thinking about that transition and have gone through, you know, a lot of our patients have gone through surgery and chemo, perhaps before they had treatment, they were premenopausal and now they're menopausal, or they've had radiation and so they've had a lot of tissue changes, or it's just been time. And what do you recommend to people as they're sort of saying, you know what, I want to start dating again. I want to think about, you know, changing this component. What are your thoughts or recommendations?
I would say start with yourself. We do tend to focus on partnered sex, but to be realistic, most of us engage at some point in our life with solo sex, which we call masturbation. But that word has such a negative connotation. And I think it's an excellent way to explore the changes in your body, to get comfortable, to get reacquainted, so that you can tell a potential partner, if that's what you decide you want, what you need, what works for you, what areas to be careful of, and even to really address for yourself where you feel insecure, because most people come through cancer treatment or any other chronic illness that affects their sexuality often feeling very vulnerable and feeling very insecure about how either an established partner or a potential partner may respond. And dating is intimidating enough without being concerned about what happens when we get to sexuality. So yeah, start with yourself. And I think you'll be pleasantly surprised at how most partners are not thrown off that you've had this happen in your life, that you've undergone treatment, that maybe your body functions a little differently than it used to. They're not going to know how you functioned in the past, and every partner is different. You know, and oftentimes we also forget, you know, for those of us who might have vulvas and hysterectomies and changes in our vaginal functioning, that in similar stages of life, if we have male partners, they're going to be facing things like erectile dysfunction. And if we have female partners, they're also going to be facing menopausal changes. So we're all in this changing body thing together, and it's okay to talk about it. And it's okay to say, sex is going to be different, but it can still be just as satisfying.
You almost wish to end on that because that's such a great line, but we still have more time, so I don't want to end. Can we go back a second to moisturizers? Because we talked about, for lubricants, we talked about water-based and silicone-based, and we mentioned moisturizers, but, you know, I have patients ask me, like, I heard I can use coconut oil. I heard I can use vitamin E. Are there other moisturizers that are worth talking to someone's doctor about or asking if they're appropriate, or those water-based moisturizers are really sort of should be the focus? If somebody says, well, I want to avoid all those chemicals you mentioned, can I use something else? What are your thoughts on that?
I have mixed feelings about kitchen products because they can also be just as harmful, even though they're natural, as some of the chemical products can be. And we haven't really looked thoroughly at them, but on the upside, they are more readily available. I tend to not recommend things as much that we don't have a history with to know how our body's going to respond to them. Teasley may have a different viewpoint.
I mean, I find that individual, preference for a moisturizer, one recommendation isn't going to be fit everybody. And so sometimes also it will just take some trial and error, different things. Now I can't say, go ahead.
Oh, the other thing I think is important to point out when we're looking at moisturizers and lubricants, a lot of us still need to use condoms for safer sex practices, and a lot of lubricants and moisturizers that are not commercially produced are not compatible with condoms. So you may be putting yourself at risk of condom breakage. So I apologize for cutting you off, but I think that's an important thing for us all to consider too.
Absolutely, absolutely right. So for example, you were talking about coconut oil or mineral oil or any of those oil-based products can have a potential to degrade condoms, which yes, absolutely, that's a really nice point. I'm curious if you have any experience with moisturizers like hyaluronic acid.
From working with clients, they really seem to be very effective and very satisfied with these. There's not a lot of research, and most of the research that has been done by the companies who are trying to sell them. But they do tend to be more favorable outcomes. And so I'm a fan of the hyaluronic acid containing moisturizers. Yeah.
What about some of the things you see that, we all sort of hear the ads and see, like DHEA and Asphena based products? What do you, when you're dealing with cancer survivors in particular, what are your, thoughts or cautions maybe about those products? What do you tell them?
So I think they can be very good options, but I always recommend that you talk to your own oncologist because they know your cancer history best. They know your hormone susceptibility best. There also is an over-the-counter DHEA available by mail order that is not by prescription. So yeah, I think it's always important for any of these, even supplements. There are a lot of supplements out there that actually can be beneficial for desire, for arousal, for your responsiveness. Supplements can also interact with your medication. So it's always important to be very open and very honest with your oncologist about what you plan to use.
Yeah, I agree with that, Tammy. Even over-the-counter medications, we know Tylenol or ibuprofen can have their own risk profiles, even if they can be over the counter. So if we're talking about DHEA, which if you aren't familiar it can be a precursor can be converted in your body into sex hormones. So it itself is not an active sex hormone, but could become or be converted to And because there is a form that is by prescription, it's something that I would always encourage you to speak with your oncologist about first before pursuing. And then if if your oncologist is supportive and thinks that it would be a good fit for you, then to look forward to the prescription or an over-the-counter version.
Mm-hmm.
Yeah, I think you can never be too touch base enough with your provider.
Yeah. You work too hard to stay healthy to make a misstep by making a decision like that on your own.
Mm-hmm.
Yeah.
What about things like diet and exercise? Are there any tips and tricks of how diet and exercise can impact all of this as folks are thinking about
Absolutely. Whatever is good for your overall health and well-being is good for your sexual health and well-being. Keeping yourself well hydrated, drinking adequate amounts of water helps to keep the vaginal tissues adequately hydrated. So that's going to help any of these treatments that we've talked about. Diet and exercise. Often we'll talk with women who maybe are having orgasmic challenges. Maybe orgasm doesn't come as easily as it used to. Sometimes just going for a walk, getting the blood flowing, helps you to orgasm more easily, especially when you haven't been active. And it doesn't have to be strenuous. Your genitals work from what we call perfusion. It's basic blood flow. You've got to get good blood flow to the genitals to have good sexual response. And that includes lubrication, that includes arousal, that includes orgasm. So anything that makes your overall body or mind healthier is going to make your sex life better. So yeah, it's another good reason to take good care of yourself.
Yeah, for sure. Those small blood vessels that contribute to arousal and erection of those erectile tissues. If you are having issues with your arteries anywhere in your body, those are going to be some of the first places where those symptoms can show up. So, we know of it maybe more so with erectile dysfunction in men with coronary artery disease or arterial diseases, but same thing can happen with all folks with, so anything that would promote overall health, like Tammy was saying, is great for the genital health as well. And then also we know from like chronic pain science and research that people who have more profile, women or people assigned female at birth, tend to have a really good response to pain with aerobic activity. And so that can even just be 30 minutes of brisk walking a day can have a big impact on pain. And that's any pain, but pelvic pain maybe more specifically today.
Yeah. Another thing I want to point out, depression in our culture has such a stigma. And depression tends to go hand in hand with cancer, any chronic illness. People who have depression are more likely to have sexual challenges. People who have sexual challenges are more likely to become depressed. So oftentimes if you notice a change in yourself, or sometimes it's your partner who notices that you are not yourself, it's important to bring this up with one of your healthcare providers, whoever you feel you can talk to about it, because, with all the options that are available, there's no reason to let untreated depression stand in your way of having a healthy, intimate life. And please don't let the stigma of depression get in the way of you seeking treatment, because life can be so much better when you have effective treatment.
I think that's right. I'm getting a warning that we're coming to the end, and I have to admit I never like ending. I feel like we've touched on so many wonderful things, and we could keep going because I have more questions mapped out here. But is there anything that we touched on where you wanted to draw back and clarify or expand on something, or anything we haven't touched on that you're like, oh my gosh, I can't believe we haven't touched on this? I feel like what you said about the importance and the interplay of all these things in depression, and making sure we are taking care of ourselves in total and not viewing any of these through the lens of something that might have a stigma, but rather something that's, a medical issue critically important to address is so important. In the past decade or so, pain became a new vital sign. And I often think when we talk about this that, for women specifically, vulvar vaginal health, sexuality should almost be like a vital sign, because whatever it is for that person, so just the general question, are you satisfied with your sexual health, broadly, however you define that for yourself, it is such a marker for all these other things and for general health and well-being that it doesn't get enough attention, and pain didn't used to get enough attention. And so I feel like if this was a new vital sign, it might get the attention that it deserves, because it would just open the door to conversation, which I feel like is something we need so badly.
Yes.
So
I'm for that.
yeah, right. I feel like it's a good marker. But is there anything else that you guys feel like we should have brought up or we didn't mention, or you want to draw back on, or
I would just say in closing, my sex life does not look like Teasley's sex life, does not look like Stephanie's sex life, does not look like your sex life. And no matter what messages you've gotten, your sex life is your sex life. Do it your way, enjoy it your way. And please don't hesitate to bring it up, to talk frankly with us about it, and to ask for help, because there is help available if you're struggling.
absolutely.
Yep.
Thank you, ladies. I am very, very glad you joined us tonight and that we had such a nice conversation, and appreciate all the back and forth. And thank you to everybody who joined us. There is certainly much more that could always be said. So hopefully you got some tidbits tonight to go back to talk to your providers and your partners or yourself about as you think about all of these issues. And we hope you will join us next week, where we will be talking about clinical trials. So we will be continuing. So thank you very much, everybody. Have a good night.
Thank you.